you for attending our Q&A session. I'm Sarah. I'm the pharmacist in the pediatric and adult CF clinics. I have a few slides on Alyftrek and the updated modulator safety monitoring guidelines. Of course, please ask questions. That's what I'm here for, to help answer. And if I can't get you an answer, I'll get you one later. But just to start us off, let's see. So we have a new modulator. We spent a lot of days trying to figure out how to pronounce it. It is pronounced Alyftrek. I still can't even say it. Alyftrek. It was approved December 20th, 2024. It is approved for ages 6 and older with at least one F508 deletion mutation or another responsive mutation. So pretty much any of the mutations that were approved for Trikafta, our other triple therapy modulator, Alyftrek, is also approved for. It also is approved for 31 additional mutations that were not previously approved for any of our other modulators. Alyftrek is a once-daily triple therapy modulator, so it has vanzacaftor, tezacaftor, and deutivicaftor. Tezacaftor was also in our Trikafta, but basically in CF, the cystic fibrosis transmembrane conductance regulator, just a fancy term for CFTR protein, it doesn't work properly, and so it's not facilitating that sodium and chloride ion exchange, which most of you already know or already aware of, and this can lead to the buildup of mucus, and the blockage is throughout the body. So tezacaftor and vanzacaftor are considered what we call correctors, and so they work to fold the CFTR protein appropriately and bring that protein to the cell surface. And then deutivicaftor, which is most similar to ivacaftor. Ivacaftor has been in all of our other modulators. It basically is, the deutivicaftor is basically ivacaftor, it's just got a little tail on it, and this makes it last longer. So hence the once.
Sarah, you're muted.
Sorry, she'll probably be back in just a minute.
I'm back. I don't know what happened.
All right, we can hear you.
Let me reshare my screen. All right. Can everyone see my slides again?
Yes.
Okay. So we were talking about deutivicaftor. It's got a little tail on the end, works very similar to ivacaftor. It just lasts longer, so only once daily dosing. But basically, it acts as what we call a potentiator, and it keeps those CFTR proteins open that are now at the cell surface. So the most common side effects that we're seeing in the clinical trials, very similar to Trikafta: cough, respiratory infections, headache, throat pain, rash, fatigue, sinus congestion, abdominal pain, and then elevated liver enzymes. And then similarly to Trikafta, besides the elevated liver enzymes and the headache, these other side effects do typically resolve within 2 weeks if they occur. Alyftrek does not carry any contraindications, but should not be used in patients with severe liver impairment. And there are 2 tablet formulations. So we have these circle tablets that are about the size of a pea. They are indicated for ages 6 to 11 years old in patients that weigh less than 88 pounds or 40 kilos. And then our other tablet formulation is this oval oblong tablet It is for patients that are either older than 12 years old, or if they're between the ages of 6 to 11 and they weigh more than 88 pounds. So this is a super busy diagram, but I do think it's important to review when we're considering who is eligible for Alyftrek. So just to orient you to the slide, at the top in teal, we have our first, we have our phase 3 clinical trials for our patients that are age 12 and older. And so these are called the Skyline trials, Skyline 102 and 103. Patients were initially screened for eligibility, and they were excluded if they had a history of hepatic cirrhosis, lung infections that were secondary to Burkholderia or Mycobacterium abscessus, transplant, or if they had a history of intolerance or interruption of Trikafta therapy. And then once screened, all eligible patients went through a Trikafta run-in period. So ETI is what we call Trikafta. And after that 4-week period, they were either randomized to Alyftrek or remained on Trikafta. And then for our kiddos, ages 6 to 11 years old, here in the orange down here, there was the Ridgeline 105 trial. Similarly to the adults trial or the 12 and older trial, there was a screening period with the same exclusion criteria. Then there was a 4-week run-in period with Trikafta, and after that, all patients in this trial switched over to Alyftrek. So most important thing to note here is that patients that were previously intolerant to Trikafta or had to have dose adjustments for whatever reason, they were completely excluded from this trial. So just comparing our 2 triple therapy modulators, there are many similarities. We got Trikafta here on our left, and we've got Alyftrek on our right. So Trikafta is a twice daily modulator you take with a fatty substance. Alyftrek is a once daily modulator that you still take with a fatty substance. Our Trikafta is approved down to 2 years old, and so there is a granule formulation as well as a tablet formulation. Since our Alyftrek is only approved for 6 and older, there's only the tablet formulation right now. I will add they are doing additional studies down to the age of 1 year old for Alyftrek, so hopefully more to come soon. As for clinical impact, both modulators are very similar. So both show lung function improvement, both show sweat chloride reduction. However, Alyftrek did show a slightly greater sweat chloride reduction in the clinical trials for the 12-year-old and older groups. There's also BMI increase in both modulators, and then pulmonary exacerbation decrease as well. Side effects, about the same between both modulators, but I will add that the side effects reported in the Alyftrek randomized group compared to the Trikafta randomized group had a greater percentage reported, but all side effects were generally the same. And then, not that the patients usually see the cash price, but in case anyone is interested, Alyftrek is about $2,000 more expensive than Trikafta per month. So there has been an update for our safety monitoring recommendations for both Trikafta and Alyftrek. Basically, liver injury has been reported within the first month of therapy on Trikafta, as well as up to 15 months following initiation of the medication. And so because of this, the liver function monitoring is now recommended to be monthly for 6 months, and then quarterly for a year, and then annually. And since Alyftrek does contain tezacaftor, which is also in Trikafta, it also carries the same liver monitoring recommendations. So before we had quarterly monitoring for the first year on medication and then annually, and now there's pretty much 18 months of aggressive monitoring. So it's going to be monthly for 6 months and then quarterly for the year after that. And these are the liver function tests where we draw blood for. As for the eye exam recommendation, it's the same for Alyftrek and Trikafta, and actually any modulator that our patients may be on. So we do recommend annual eye exams for all patients under the age of 18 on a modulator. And this is to rule out any signs of cataracts, which were seen in the very initial Kalydeco trials, which Kalydeco is just that ivacaftor. There was a couple cases that were noted. And so ever since then, any modulator is recommended to have annual eye exams for the patient up until the age of 18. All right, so behavioral health has been a hot topic in our CF community, especially in the setting of CF modulators. So I did want to make sure to comment on that in the new Alyftrek trials. So Vertex did look a little deeper into neuropsych events in this modulator. So this is another really busy slide. Let me orient you to it. So on our left side, we have our Ridgeline 105 trial. This is for ages 6 to 11 years old. There were no discontinuations of the medication due to neuropsych events. However, there were 2 patients that reported initial insomnia. There was one who reported aggression and one who reported anxiety. And this is out of 78 patients. And then on the right side was our 12 and older trials, so the Skyline trials. We did have some study drug discontinuations. So in this table, this orange column right here is our Trikafta group, and then this white column is our Alyftrek group. So in our Trikafta group, there was 12% of patients or 59 patients who reported some sort of neuropsych adverse event. And then in our Alyftrek group, there was 11.5%, so 55 patients. So 2 patients in the Trikafta group discontinued the medication. 3 patients in the Alyftrek group discontinued the medication because of the neuropsych events. And then we had 3 in the Trikafta group who had an interruption of medication therapy, and then 2 in the Alyftrek group. And this was not evaluated in the early Trikafta studies. All right. So Alyftrek is not going to be for everyone. In fact, most are choosing to stay on Trikafta if they're tolerating it well and if they're healthy. But of course, there are patients that would be an ideal candidate. You could argue that even though patients were excluded that did not previously tolerate Trikafta from the trials, once more data comes out, Alyftrek could be an option. These patients that have the 31 additional mutations that Alyftrek is approved for, but have not been approved for any of the other modulators would be excellent candidates. Those who aren't responding to Trikafta as great as we hoped, or other modulators for that matter, some of our patients are actually asking to be re-sweated to help guide these therapeutic decisions, since the Alyftrek trials did show a greater reduction in sweat chloride. And then, of course, those who want to simplify their regimen to once daily versus twice daily. Most patients are on other medications that unfortunately have to be twice daily, so this hasn't been as big as I think Vertex was hoping, maybe to help adherence. But yeah, of course, if anyone's interested, we're happy to discuss the medication. I'm happy to take any questions if anyone else ended up joining our discussion today.
Hey Sarah, it's Drew. Thanks for that great presentation and overview. I was wondering, since you mentioned there was the tail on um the Duver Ivercaptor.
Dutivacaftor.
Yeah, that one. And the side effects are similar. Do we, I guess I'm just trying to predict and kind of think about, are they different enough that they might have different side effects, or are they similar enough we would expect the same side effects?
So I can pull up the side effects table that were reported in the trials, but pretty much the only thing that changed with this molecule was making the half-life last longer.
Mm,
So they are pretty much assuming that side effects to ivacaftor are going to be similar for dutivacaftor. They don't have any, there's no way to pull out which molecule is, of course, causing the side effects, since it's all taken at one time. And like
right.
before with Trikafta, you could cut out the ivacaftor tablet, for example, to kind
Yeah.
of further assess. But with this one, since it's all taken at one time, you can't do that. But just to
So longer half-life, do we worry about like more liver accumulation and like harder to get out? Harder to clear, I guess I should say.
so I guess in terms of it will last in the body a little longer. Is that what you're saying? Like,
Mm-hmm.
yeah. So I mean, in terms of what to from what I think, what to worry about when it comes to the liver, for example, we have no idea which molecule is causing the issue. So since nothing was changed for the other two molecules, tezacaftor has a really long half-life. So that one is already lasting in the body for, I think it's like 19 hours or something, 24 hours. It's a pretty long one. It may even be longer than that. So I don't think we have to worry more about the fact that dutivacaftor is lasting longer, just because it's about the same as the other half-life of the other molecules.
Thank you.
Mm-hmm. But I will say the LFT elevation was slightly higher in the Alyftrek arm than the tezacaftor arm. I'm going to pull up the table here in a second.
For any attendee, feel free to type a question into the chat box if you have one, or you can also come off mute and ask a question. But don't be afraid to ask any questions. No questions or stupid questions. And anyone else who's been sitting in these meetings and has any input or thoughts that they'd like to add, feel free to chime in as well.
Trying to find that table. All right, this is the 12 and older trials. This was the side effect profiles that were reported. ALT was increased 6% in the Trikafta group versus 8% in the Alyftrek group. AST was 5% Trikafta, 7% Alyftrek. And then, let me see.
Oh, can you hold on that page? Ineffective pulmonary exacerbations. Huh.
So this is most talking about that purge that they get at the beginning. They usually identify that as exacerbations, and if they have grown some sort of bacteria recently, they attribute that to it. as they're coughing up all that mucus.
Yeah. I don't know. That's just interesting. That's like a 4% decrease there with an increase in cough. And so it's just wondering if it's as, effective or if it, did they test that like statistically? Is there a p-value or I wonder what that would be.
For the side effects? Or the
Mhm.
adverse events? Yeah, let's see. I'm not sure if there's an actual p-value. I can pull the study up though. There was the same number of patients in each group that had to discontinue the medication due to LFT elevations though as well.
Hey, Sarah, I just wanted to clarify too, in case any of our patients are listening later that, or now, that if you've already been on Trikafta and stable for greater than, a year and a half, that your liver monitoring doesn't change, that it doesn't have to start over or anything like that.
Thanks. Do any of the providers on have anything they'd like to add to the recording for those that might watch later?
Hey, Sarah, Dan Howard here. I just put in the chat that at the same time Alyftrek was approved by the FDA, there were also 90 some additional mutations that were approved for treatment with Trikafta. Those are also included in the approval for Alyftrek. So there are patients who may not have been candidates for Trikafta in the past who are now. That would also be included in the Alyftrek candidates as well.
Sorry, and I want to correct myself. I think I said just a minute ago that the same amount discontinued in both the Trikafta arm and the Alyftrek arm for elevated LFTs, but that was not the case. It was 3 discontinued in the Trikafta group and 7 discontinued in the Alyftrek group, but there were the same amount total that discontinued from all side effects. For anyone jumping on, we are just about wrapping up in case you have any last minute questions, but this was recorded and it will be sent out.